Yes, sir, we are live now.
Yeah.
Can I start?
No, let
Yeah,
me.
Yeah,
we will
yeah.
wait for 7 p.m. It's a little bit short.
Okay.
Just
Okay.
2 minutes. Yes, sir, we can start.
Yeah. Uh, yeah. Good evening, doctors. My name is Dr. Ketan Kulkarni from the medical services team at MQ Pharmaceuticals. So, on behalf of everyone at MQ, I invite you for this webinar on Croi 2026 ART updates, and the updates will be presented by Dr. N. Kumar Swamy, sir. So before we start, let me invite Mr. Balaji, sir, who is heading the ART business at MCure, domestic as well as international, to say a few words. Mr.
Thank,
Balaji, sir.
yeah. Thank you, Dr. Ketan. On behalf of MQ Pharmaceuticals, we take pleasure in welcoming all the joinees who have logged in to attend this webinar. It's been an annual event for many years that MQ has been hosting the updates on Croi and also updates from IAS conferences. And we are happy to tell you that there have been, it's not only a pan-India event, it's for a few years uh, in the past, it's been a event there where we have been having logins. It's been worldwide logins right from Canada to Australia and all countries in between. Much about the fan following that this has scientific event has stimulated. We are also happy to inform you that on the website we have live recordings of this event that have capsules that are more than, I think, about 54 such events are available at the click of a button for people who have not been able to attend in person, but can always go back and at your leisure go through this discussions. So these scientific discussions have been quite encouraging in that there is it captures the latest happenings that is evolving in the field of HIV medicine. And who best to take us through this than our own Dr. N. Kumaraswamy. Much as Dr. Kumaraswamy is a well-known figure among us, it's only right that Dr. Ketan introduces Dr. Kumaraswamy to those who are attending. Over to Dr. Ketan.
Yeah. Thank you, Balaji, sir. Uh, so I'm introducing Dr. N. Kumar Swamy, sir, who is the Chief and Director at VHS Infectious Diseases Medical Center in Chennai, India, and also the Director of Chennai Antiviral Research and Treatment Clinical Research Institute. And he is the expert panel member of WHO ARV Treatment Guideline Committee. So to further introduce sir, uh, he has been the clinical investigator for several ongoing clinical research projects with esteemed universities across the world like University of California, Brown University, Harvard University, University of Colorado, University of Washington at Seattle, University of New York, also the Kirby Institute at Sydney, Australia, Treat Asia Network, King's College London, National Institutes of Health, WH and ICMR. He is also involved in investigator for the clinical development of several antiretrovirals. And Dr. Kumar Swamy, sir, has conducted several landmark antiretroviral clinical trials and which has impacted the clinical treatment guidelines. His publications on the impact of generic antiretroviral therapy has led to several antiretroviral scale-up programs in developing countries. So he has more than 50,000 citations and his H index is 88. He ranks among the top 2% among the scientists globally in the field of clinical virology. He is an advisor and expert panel member of WHO ARV treatment guidelines committee, also the clinical advisor to the Clinton Health Access Initiative. He also serves as the member of US DHHS treatment guidelines for opportunistic infections. And he has particular interest in long-term impact of antiretroviral therapy in resource-limited settings and the impact of climate change on emerging infectious diseases. And he also serves as the editorial committee member for several medical journals. So this webinar, Dr. Kumar Swamy, sir, will be presented on the updates of the Croi conference, which was held in February in Denver, Colorado, USA. And he'll be presenting the important trials and important uh, things which were presented in the conference. So I invite Dr. N. Kumaraswamy sir to share his screen and deliver his presentation today. Thank you very much, sir, for accepting the kind invite. Thank you, sir.
Sure. Thank you, Dr. Ketan, for the kind introduction, and Mr. Balaji and MQ for inviting me to do this retrovirus update. And good evening, everyone. I know some of you have been from other parts of the world. It might be a good morning or good afternoon. Thank you again for joining, on this Saturday. So I'm going to share my screen, and Ketan, can you tell whether you're able to see this?
Yes, I can see.
Now I have to put it up as a full screen, and you can see the slides, right?
Yes.
And it's moving, right?
Yes.
Okay. So what I'm going to do in the next probably 40 minutes or so is I'm going to give you an introduction of what has been happening in terms of antiretroviral therapeutics. So Croi is a very famous. Many of you know that is a very famous retrovirus conference. Happens every year in the US, where the key cutting edge research has been getting presented. Usually happens in the last week of February or the first week of March, where it's been focused on all the new data. Anyone who's developing new molecules for either for HIV, hepatitis B, hepatitis C, or any other viral diseases, or even including for TBs, all been presented at this meeting. So today, what I'm going to do is I'm going to give you key updates on antiretroviral. It's a 4-day conference where I will not be able to speak to you in the next 40 minutes about everything what's happening. But on the other hand, I'm going to give you a key update on antiretroviral therapeutics, particularly, whether it will make an impact, especially in our clinical practice in the next 2 years or 2 to 5 years or so. And also, I focus mostly towards lower and middle income country, especially on some of those drugs which might be in future will get into our treatment guidelines. So the outline of my talk is I'm going to give an update about the updates from the current treatment and about some of those emerging new HIV treatments, from the new data, and also about some of those newer antiretrovirals still in the early phase 1. And many of those which I'm presenting now, you may not be able to prescribe tomorrow or the next week. It's very important to understand what had happened in terms of data. Many of the data which I've been presenting is not even published, just presented, and some of them just got accepted, or some of them still under reviews. So it's just to orient yourself that, how you can align yourself in terms of managing patients, over a period of years, And today is not the end of the show with the current first line, second line, third line. There are a lot of new drugs under pipeline. Now, moving to the current HIV treatment, what's the new data available from this retrovirus conference? As all of you know that this Cabenuva, it is a combination of cabotegravir and rilpivirine as a long-acting injectable, which has been developed with a half-life of almost for 3 months. And there are pivotal studies like GLACI2, ATLAS, and FLAIR have demonstrated that, especially in patients who have got previously have undeclared viral load, if you give these to injectable drug every 2 months, you'll be able to maintain viral suppression. So following this, the US DHSS guideline recommended this as a therapy, especially for maintaining people living with HIV who have been poorly adhering therapy or who don't want to take these medications for every day. And late last year, following the outcome of the CARE study, which was done predominantly in the lower and middle income countries in sub-Saharan Africa, World Health Organization also recommended anyone who got a suppressed viral load, this particular combination can be used as a maintenance therapy. So this was 2 years back, US DHSS guideline recommended, particularly in people who have been susceptible both to cabotegravir and rilpivirine, where this long-acting injectable is being recommended. And the World Health Organization guideline late last year, there are several new updates. And along with that, one of the key updates was, one was this, someone who suppressed viral load, you can even move them to a 2-drug therapy of dolutegravir and lamivudine, especially to prevent bone toxicity and kidney toxicities, and also been recommended following the CARE study, where a long-acting injectable of cabotegravir and rilpivirine every 2 months is an alternate option. So this is something that's been recommended, but not been widely practiced in lower and middle income country, even including in the research settings is getting into that. Now I'm going to give you a little update about what happened in this Croi about the new data. So today, a significant number of patients, both the research-rich settings as well as in the lower and middle income country settings, even following the WHO guidelines, are moving towards this combination of lamivudine and dolutegravir. It's a 2-drug therapy, especially people who have got suppressed viral load, were not recommended in TB and hepatitis B co-infected people. And also this combination has also been recommended in the research-rich settings, even in people to initiate treatment if the viral load is less than 500,000 copies. So a significant number of patients are already being moved on to this, both in research settings as well as in lower and middle income countries following these guideline changes. Now in this retrovirus conference, there are data presented, especially on people who are already moved to dolutegravir 3DC, where they have suppressed viral load. If we change them, these individuals, when this long-acting cabotegravir and rilpivirine available, how is his treatment outcome and as well as adverse events and so on and so forth. Again, as many of you know that this dolutegravir 3DC is a very good combination, especially in people who are more than 50 years of age and as well as in postmenopausal women who are at a high risk to develop kidney disease or bone disease, where it can get away from these, all been shown in different studies and following these recommendations being done. So in this conference, there is a phase 3B data being presented, a trial called Oliton trial, where this was carried out in patients who have been treatment naive and who had already have a suppressed viral load and who have been moved to dolutegravir 3DC, and following them, they switched to long-acting cabotegravir and rilpivirine. So a 11-month outcome data, which has been presented at this conference. So this is the brief design of the study. It is on 171 patients who had previously had a high viral load, who had been received but less than 500,000 copies, who were initiated on dolutegravir and 3DC, where they received up to 4 to 16 weeks, where when the viral load went to undetectable level, they were being offered either to go on long-acting cabotegravir rilpivirine or to continue with this based on their own choice. Out of the 171, 129 individuals decided to go into the long-acting dual because they don't need to take these tablets every day. So interim analysis at the 11 to 12 months was been presented at this conference with a co-primary endpoint of patients achieving less than 50 copies and as well as maintaining these at 11 months. And with several secondary endpoints on CD4 and failure rate and resistance and safety, tolerability because an injectable and acceptability. So on looking at quick shot on looking at this virological outcome, so it's almost 95% of them, they're able to have, less than 50 copies and they're able to maintain, whatever they have achieved earlier. So I think this is something what's been is very important, where even in moving from everyday oral therapy, especially from a simplified regimen of 2 drugs of 3DC and DTG to these long-acting injectable, they're able to maintain the suppressed virological suppression. So in this particular study, there is one participant who had a failure, also had developed resistant strains, and they developed a genotyping mutations to emergent to integrase and NNRTI. As you know, that cabotegravir is an integrase inhibitor, is an analog of dolutegravir, and again, rilpivirine is an NNRTI, where they develop a resistant mutation. And subsequently, this patient was moved to darnavir-containing therapy and further got a suppressed, viral load. So there is no major other untoward events happened. It's the only incident happened in this particular study. Otherwise, all other participants did very well. Looking into the safety, because it has been injectable, of course, anyone who receives any injections, they can have some pain. Here again, this has been graded. So no one discontinued because if they have been severely painful or there is no serious adverse events or no death happened. But they were all minor injection site reactions were reported, but primarily all grade 1 and 2, all resolved within a median day of 3 days. So it has been so far been very safe, and patients are able to tolerate no major adverse events. And very importantly, in these studies, you also need to know that whether the patients like this, because they are all being used to this oral tablet, and for many, many years they were on this. So they enjoy doing that every day, whether it is for compulsion or not, they did that. But when they move them to the injectable, whether they like it or whether they'll come back for the next dose or not. When they did this, and almost 90% of them, 89% of them responded that they'll continue to on this long-acting capital rilpivirine. They like these injections. So I think that is also very important, not just bringing the product, but the patients will like to get for the future options. So this particular study, they concluded stating that this moving from a simplified 2-drug therapy to long-acting capital rilpivirine will be able to maintain virological suppression and was been well tolerated and can be a future option. So now we have got an option. Someone who is on 2-drug therapy, when you have options to long-acting capital rilpivirine, you can always discuss with the patient, hey, now you are suppressed 2-drug simplified. If you don't want to take this tablet every day, or your family members are not aware of your status, keeping this medication at home is a stigma for you, where there's an option on 2-drug therapy. I think this study very clearly shows that can be a great option, particularly for low and middle income country. Now, these are all been carried out in adult population, where all those pharmacokinetic studies had been carried out. So can we use this in adolescents? Where it is a very difficult population. There are many studies have been done, particularly in adolescents, especially 12 years to 18 years. The oral therapy adherence has been very poor. Enough data already been published on that. So US NIH Impact Network have done some studies using the long-acting cabotegravir and rilpivirine, and they've shown they're able to maintain suppressed viral load even in adolescents population they presented in the past. So in this particular conference, that group also did some long-term safety study up to week 96, and as well as the efficacy and pharmacokinetics. It's very important because that's entailed a different population of adolescents. Their body weight has been different, and their organs are getting developed, and their lifestyle is very different. Are they able to see the same type of safety events and as well as the pharmacokinetics and drug distribution? So this is the design of this study, where adolescents of 12 to 18 years, who have got a suppressed viral load, 144 individuals, but with the body weight of more than 35 being recruited. They have switched to this long-acting cabotegravir, initially oral tablet. It's an everyday oral tablet. It's not a long-acting. Make sure that they maintain this drug level. Then they're moved to, after 4 weeks, to long-acting cabotegravir rilpivirine, every 2 months, with the primary objective of safety and secondary objective of those tolerability and as well as PK at week 96 and the end of the study. It's been shown that there are no serious adverse events, and there are adverse events like grade 3 events have been reported, but they're all been very mild. There are one participant had an anaphylaxis. So it was being discussed internally by the team, whether it is due to the drug or by some other things. But again, the participant was removed from the study, did not have any major untoward event after that. So that was the only event which had happened, but otherwise been safe in this 144 patients trial. And they looked in the injection site reactions. Again, similar like in adult population, most of the events were all grade 1. And also they looked into the post-injection reactions, whether how was it in the, after giving that, except that one anaphylaxis, there was nothing's been reported. It's been very safe. And also they looked into some of those participants' willingness to come back and do questionnaire. They also found similar like in the adult population. They're able to maintain viral suppression at week 96. And also they did some the pharmacokinetic studies, because it's very important whether they're able to maintain over a period of time, not just in the first few injections. And they found that they're able to maintain these cap concentration and rilpivirine combinations, and we have been accumulating even at 96 and beyond. And they also found these what is called the acceptable levels of median and 5th and 95th percentile of trough concentration of capture and rilpivirine, comparable with the adult median trough for these for the randomized study of ATLAS, which happened in an adult population. So that means even in adolescent, the safety has been established, and as well as the pharmacokinetic interactions, and as well as the trough levels. So following these the investigators concluded stating that this can be another option, especially adolescents who will not adhere to the everyday oral therapy, where this every 2 months of long-acting captopril rilpivirine can be an option. So moving to these are all clinical trial data. So moving to the real-life data. So the only data available is only from the US and some parts of Europe, because it's not widely available in resource-limited setting. So this is a data presented from a cohort called OPRA cohort, which is in the US, where they collect data from the routine clinics using electronic medical records. So, so they collected data from ART experienced patients of more than 18 years, where we have initiated on captopril rilpivirine long-acting between 2021 and 2024 of more than 5,000 patients. So they stratified into 2 groups. So here in the clinical trials, it's all been used on patients who got suppressed viral load. Here, there are some clinicians who had also been prescribed this in patients who got more than 50 copies. That is not part of their US guideline, but they still prescribe because these patients are not adhering to the oral therapy. Almost 4,500 patients with less than 50 copies they initiated on this. These are real-life clinic patient data, and 500 odd on more than 50 copies. So they analyzed with the different groups with what happened in the less than 50 copies as well as in more than 50 copies. And they found, irrespective of the initiation viral load, less than 50 or more than 50, they're able to see the virological suppression commonly achieved and maintained regardless of the initiation. And they're able to persistently maintaining this. So this is something, again, is great. Even in a real life, patients put on these long-acting captopril and rilpivirine, we're able to maintain and the virological suppression. So I think this is very important. Now, real-life data shows that I think this is time when this product is available here in our country. It's time to move on, especially for patients who may not adhere to everyday oral therapy, or physicians feel that they may not continue with these everyday oral therapy. I may talk a little about the availability in the next few slides. The moving to the next long-acting is lenacapavir. As many of you know that now it has been licensed even for lower and middle income country for prevention. So it's been developed both as an oral tablet. I'll show some data, very interesting new data on that, and as well as, of course, as a subcutaneous injections every 6 months, which has been now recommended for prevention. But there are 2 trials in the past. I think in previous meetings I had presented to your group. One called Calibrate, called Capella, one on ART naive patients, another one on patients who have got a severely experienced and failed. Both have shown, lenacapavir has been very effective with other background regimens of every 6 months on long-acting. And following this, now US FDA have also been approved, and US guidelines have recommended anyone who is having MDR HIV, multi-drug resistant HIV, where lenacapavir long-acting, it's been recommended along with other optimized background. It's been already been now recommended. Now trials had been done on that. I think I've shown in previous meetings. So here in this conference, there are some case series being presented, especially from clinicians who are prescribed on these MDR HIV, where patients have multi-drug resistance. So this is one program they have. It's called SPLASH program in San Francisco, where they have been offered free lenacapavir as an access program, where they have been prescribed, this around 50 patients been recruited for this particular analysis. Out of those, 28 had been prescribed when the viral load is more than 30 copies. Another 22 had a virological suppression. So it has got a both, and also they captured the previous resistance profile as well as what are those background regimens they were all on that. And again, the analysis on time to less than 50 copies on patients who started on this lenacapavir with viremia, as well as people who were on suppressed. So very interestingly, what they found in that is, so when before initiation of this lenacapavir, when they had this MDR-HIV, the optimized background with whatever available drugs, with only 44% virological suppression. So when they added lenacapavir every 6 months of subcutaneous, and they're able to even move them to 100%. So that means this drug is extremely working well, even in MDR-HIV, where is an added boon. So something has been seen in this case series of 50 patients, where again, they're continued to follow these patients over a period of time. So here they presented at the week 148 data. So probably we'll wait to hear from them more and more on about the long-term virological suppression of this molecule of long-term with other optimized background. Also, another real-world lenacapavir study data been presented from the United States, where it's again a retrospective analysis from a database of 300,000 patients who are on antiviral treatment. And out of them, 93 have received lenacapavir injections. They recruited only people who got more than 2 injections, and they have at least 2 viral loads been present for this particular analysis. And again, outcome analysis been analyzed using various variables just to understand how is the virological suppression and the safety. So I'm not going into very details. I think for this crowd and for clinicians, just to say that, so if you look into this, patients who have got MDR-HIV and as well as who have got been suppressed viral load, where when we move them to this in a real life situation, over a period of now 18 months, if you see this blue color bar, it is on less than 200 copies, and the orange one is on less than 50 copies. They're able to maintain virological suppression, not like more than 95%, because these are the patients where they don't have any other drug. Most of the other antiretroviral drug, first line, second line, even third line are all been resistance. They have some optimized background based on the resistance profile, where lenacapavir as a new drug has been added as a long-acting injectable. They're able to do this. So I think lenacapavir will make it to even might be one day to the resource-limited setting guideline when it has been available for MDR-HIV. So only thing is that is every 6 months. We don't have another drug to partner with that for every 6 months. All the other things, whatever we have is either everyday oral tablet or this long-acting injectable of every 2 months of cabotegravir. So still we have that. I think we have to balance how we are going to use this drug in our clinical setting. Again, in this, they found that the patients who received lenacapavir in the first injections, they were able to come back even for second injections, and acceptability was good, and very safety events been recommended. Hence now, there's another option in future for MDR-HIV as lenacapavir. So now coming to this, you may ask a question, when it is going to be available in our settings. So here comes, we use always our drugs from our generic companies, mostly from India. I know some of the participants are from Africa and India, Latin America. So your companies, the generic companies also manufacture. So there are huge collaboration happen between the innovator companies who discovered and select generics, where there is an organization, many of you know, that called MPP, Medicine Patent Pool, developed by United and WHO and London Health Access Initiative, help to assist to the technology transfer from the innovators to generics. And now many of the companies are developed, but still not launched it. We expect a generic cabotegravir in India might be launched by late 2026. And rilpivirine, I'm not sure about that because I didn't get good data from the Indian generics who is going to develop this. Lenacapavir, which is very sure that it will be launched by this year end. So all these are going to be available, generic market. Hence, understanding about this molecule, how to use it, when to use it, and about all this data is very important. You may use it even in your settings by this year end. Cabotegravir is already part of our WHO guidelines. Lenacapavir is currently been recommended in the US. In WHO guidelines only for prevention. Hopefully, when the drug is available, when we have a little more data, it will also might be recommended for the MDR-HIV for treatment. It's worth to know about all these drugs. Now, moving to this emerging treatment data about some of the newer data, which we are not part of the guidelines. Some of them will make it probably next year or so, which is in a very advanced stage. Is a trial called Artistry, which is a phase 3 trial, which compared a single tablet of bictegravir and everyday lenacapavir oral tablet. I said about lenacapavir long-acting subcutaneous. It's also been developed as an everyday oral tablet, especially on patients who are already on complex ART regimen with virological suppression. If you switch them to the single tablet, like of bictegravir and lenacapavir, which has been developed by Gilead. So it's similar like a 3TC and dolutegravir, where again, bictegravir is an integrase inhibitor, which many of you know that, and lenacapavir is a capsid inhibitor. So this particular trial, which compared the safety and efficacy of patients who are moving to either to bictegravir or lenacapavir or continuing this complex ART, whatever they were on. So patients who have got a suppressed viral load of less than 50 copies with more than 6 months of whatever ART regimen they were on, of 689 patients been recruited, they are randomized to 2 different groups with a 2:1 randomization. 2 individuals went into oral bictegravir and lenacapavir combination of everyday oral tablet. It's a single pill. And another group which went into the same complex ART what they were on, and they are followed up over 58 weeks. So with the primary endpoint of a proportion of patients going more than 50 copies at week 48, it's several secondary endpoints of less than 50 copies and change in CD4, and as well as safety, and also including the treatment satisfaction. So when they looked into the viral load measurements, so if you see this, the orange color bar chart is bictegravir lenacapavir simplification of the single tablet, and the blue one is a complex ART of everyday, whatever they have been taking on. So it very clearly shows it is a comparable viral suppression, and in fact, even much higher than in terms of the numbers. But again, it has been quite non-inferior. And also, if you see the right panel where it shows that it has been favors the bictegravir lenacapavir, and also been shows very clearly non-inferior. There is no treatment emergent resistance, and they are also able to maintain CD4 in both arms. Also looked into the safety, where it has been quite safe between the arms. I will not go into the full details. No one discontinued because of any untoward events in the bictegravir lenacapavir as compared to the complex regimens, and it has been quite tolerated, and no one discontinued because of any adverse effects. And very importantly, looked into the lipids, which is currently is very, very important because many of those antiretroviral drugs alter and causing metabolic issues in our patients. So in fact, what's been found in that is, as compared to the complex ART, a combination of bictegravir and lenacapavir is associated with the improved lipids in this particular study over week 48. I think that's very, very important, particularly in the context of in resource-limited setting in India, where we have got a high risk to develop cardiovascular diseases. And switching to bictegravir and lenacapavir is associated with the improved patient treatment satisfaction also, based on studies, sub-study which has been done using a questionnaire where participants again like this combination of this single tablet. So the Artistry 1 concluded stating that switching from a complex ART to these bictegravir lenacapavir is non-inferior, no emergence of drug-resistant strains, and favorable lipids, well tolerated, and this can be a future treatment options even for resource-limited setting, since we already have bictegravir, lenacapavir is in the horizon. Also, there is another trial being presented using the same combination of bictegravir and lenacapavir, but it was compared against TAF emtricitabine bictegravir, which is a very potent combination, which many of us use in our clinic in patients who have been initiating treatment. So these are patients who have got suppressed viral load using TAF, FTC, and bictegravir. They were randomized into 2 different groups. One group received oral bictegravir and lenacapavir, and another group, they continued the same regimen of TAF, FTC, and bictegravir over 48 weeks. Again, a 2:1 randomization. Out of the 577 individuals, there 383 were on oral bictegravir and lenacapavir, and 191 on the everyday TAF, FTC, bictegravir. They continued on that with the primary endpoint of more than 50 copies at 48 week, and with several secondary endpoints, including CD4 change and safety. So what's been found in that is, if you see these viral bars, the orange one is on bictegravir lenacapavir, simplified 93% virological suppression versus TAF, FTC, and bictegravir 90%. It's totally non-inferior, in fact, even much better on this. And again, the study concluded stating that it has been very tolerable and CD4 changes happened. And also they looked into these BMI, and as well as will be stable throughout the arm, because now there have been studies showing that where integrase inhibitors even causes weight gain, where again, whether any particular even been noticing this particular bictegravir, which is again integrase along with the lenacapavir. Coming to the adverse events, it's been found very safe, and all the events are all very minor, and no one, discontinued drug. There is one death happened in the TAF-FTC bictegravir, not due to the study medication, but due to other HIV-related conditions. So very few adverse events been seen even with bictegravir, which are all not related to the drugs. It's part of this disease. Again, this group continued stating that a combination of bictegravir and lenacapavir is non-inferior even to the robust TAF-FTC bictegravir at 48 weeks. It's been safe, well tolerated, and this can be a future option. So again, now we have bictegravir already been developed. It's been available, but along with the TAF-FTC and bictegravir as a single pill, lenacapavir is getting developed, so it can be another future option even for resource-limited study. So moving to the next combination, which is again a very nice, interesting combination of doravirine, which is very recently launched by MCure in India last month, which is a third generation NNRTI, and which was paired along with a new drug called flatravir, which is a translocation inhibitor, which is very potent, again, works against many of those resistant viruses to NRTI. So previous trials have shown a combination of doravirine and latravir is very potent and have complementary effects on that. And also previous studies also showed this latravir as a drug can cause decline in CD4, following that several in vitro and as well as small scales and large scale studies were done. And now they come up with the appropriate dosage for latravir, and which is now shows it's not declining the CD4 anymore. And with all those background, this particular trial was conducted in patients who have been treatment naive of doravirine latravir versus bictegravir TAF, and with a dosage of 0.25 milligrams, especially for latravir. There is an appropriate dosage being identified following various studies so that the CD4 won't get depleted, and doravirine is a standard dose of 100 milligram tablet. So this is again a patients, and for naive patients, people who got more than 500 copies of viral load, no previous resistance to doravirine or any other NRTIs, and no hepatitis B, which are being randomized to 1:1. The one group received doravirine's latravir, which is to initiate treatment of 100 milligrams of doravirine and 0.25 milligrams of latravir, and along with the placebo of TAF-FTC bictegravir versus TAF-FTC and bictegravir, which is the standard of care, with a placebo of doravirine and latravir. And the study was been planned for 144 weeks. But here I'll be presenting the week 48 data with a primary endpoint of less than 50 copies and with several secondary endpoints of CD4 and as well as resistance and change in body weight. So again, when you look into those viral load changes, there is no difference in between the TAF-FTC and bictegravir. Almost more than 90% of them achieved virological suppression of these on initiating treatment. And there is little discontinuation because of lack of any efficacy for this particular regimen. There are 2 participants who developed treatment emergent resistance to doravirine latravir. So these are the various resistance profile. So particularly these are the patients who developed for NNRTI, so which is doravirine. But on the other hand, the other latravir has been ineffective and other NRTI has been effective. Also, this patient also has got a M184V where it was been not exposed, would have been acquired at baseline. So when they looked into those by various subgroups and everything, and they found in that this actually it has been very comparable in terms of virological efficacy between the groups, and there is no difference in between different pattern of regimens being used on that. And also they looked into the patients who have got a higher viral of more than 100,000 copies, where again, this clearly favors that doravirine and latravir can be used even in patients who got more than 100,000 copies. Because some of those drugs, when it's been developed, which has not been studied with a higher viral load, here it has been studied, shows that it has been very potent. And when they looked into the CD4 changes, which is almost comparable in both arms, and just for the information, TAF-FTC bictegravir is a robust combination, which has been standard of care and a preferred first line, which many of you know that. So doravirine latravir is an experimental drug for this particular study. Now it has been almost been comparable to this robust combination. And when they looked into those adverse events occurring in more than 2% of the participants, especially of the weight, as you know that bictegravir can cause increased weight like a dolutegravir. where they have seen where weight gain is also seen in this, but it's not that high as compared to bictegravir. Again, large follow-up study is also important to show that whether it has got any weight preferences, particularly with this particular combination. Otherwise, it's been very, very safer. There is one individual who has got a drug-induced liver injury, but didn't meet with the drug-induced. Probably the patient also had maybe an alcoholic. Probably it could be a combination of both, or whether it is alcohol related. That further analysis is going on. And just for information, this doravirine latravir cannot be given in patients who are co-infected with hepatitis B, where TAF, FTC, or tenofovir 3DC has been preferred. Here, all patients at baseline were screened out for hepatitis B, but during the course of this study, 3 patients, particularly in doravirine latravir, were reported to have hepatitis B, but they were all being negative at baseline. So these are the patients who had acquired hepatitis B. So in the other arm, TAF FTC, which is also a treatment for hepatitis B, it can also prevent as a pre-exposure prophylaxis. Here, that advantage has been not there. I think that's also been very important for the clinicians to know that when you have been using this, the routine screening for hepatitis B has been very important. So again, the investigators concluding stating that where the combination of doravirine latravir, now it's also can be developed as a single tablet with the dosage of 100.25 milligrams is non-inferior to TAF FTC and bictegravir at week 48. And also it shows that patients at less than 50 copies is with a very high viral suppression of more than 90% in both arms. And also they looked into those various adverse events and as well as the treatment emergent resistance, which has been very comparable, only with the caveat of these hepatitis B infections. So the efficacy from these phase 3 trial data now can be extrapolated even for future treatment guideline, even for initiating treatment. Also, there is another study using the same combination. It's been presented on patients who are virologically suppressed on TAF FTC and bictegravir, and further when they are being moved to doravirine latravir with the week 96 efficacy data. So this is the design of this study. Again, 2:1 randomization. Patient who are suppressed less than 50 copies on TAF FTC bictegravir were moved to doravirine latravir or allowed to continue on TAF FTC bictegravir. And when they looked into those viral load changes, and again, they're able to maintain the comparable viral suppression even when they are moving from TAF FTC bictegravir to doravirine and latravir. And also, there is one participant in doravirine arm. They have seen who had developed a treatment emergent viral resistance, like similarly earlier in the earlier study, again to the NNRTA containing regimen. So, which is quite possible. But on the other hand, they're also been looking into that, whether it is a pre-existing mutation or it is related to this particular drug or not, since NNRTA resistance already been present in the community and also it's been pre-screened, sometimes it can get archived. The virus was still active against this latravir in this particular patient, and there is no cause of concern. Very importantly, in this trial, they looked into that lymphocytes, total lymphocyte and CD4 count. Because the previous trials have shown latravir as a drug can also reduce these CD4 cells. And based on that, they titrate the dosages to the 0.5 milligram. Here, they did not see any major CD4 significant changes in terms of going down as compared to TAF and as well as the total lymphocyte count, stating that it has been safer in terms of looking into the lymphocytes. And looking into the adverse events, it's been comparable in both arms. In fact, there are more osteopenia being seen in the TAF arm, but there is less as compared to doravirine and latravir. That's because of the TAF. Again, for such population, again, this can be another better drug even to switch, similar like a 3TC DTG to doravirine and latravir. So, and also looked into the weights and lipids. And also in this particular study, it's been found that it has been have a comparable lipids as compared to TAF FTC. It's not much better, but it's been comparable. Even in fact, even the weight has been significant, but all that has been much better than the TAF FTC bictegravir. There could be, but we may need a little more longer data to state that whether it has been lipid friendly as compared to TAF FTC and bictegravir. So the investigator concluded stating that when patients who have been suppressed TAF FTC bictegravir can be moved to doravirine latravir with a lot of better advantages. One, maintaining viral suppression, lipid friendly, and better weight friendly as compared to the TAF FTC and bictegravir. And also There is another group in the conference presented on the same regimen of doravirine/letrozole when they compared to the standard of care, not just on TAF-FTC, but whatever drugs they were on. I mean, go quickly on this because they found similar, results like the earlier studies, where they found that patients who are on doravirine/letrozole, which is on this orange color, they have continued to have a higher virological suppression of more than 95%, when they continue over a period of 48 weeks. And also they found in this, there is no discontinuation because of the decrease in the total lymphocyte count at CD4 as compared to the standard of care of ART, they were on. So that means it's been very safer now with the current dosage of 0.25 milligram. And again, there is no major significant adverse events to doravirine and letrozole. And also it's been found in that it has been statistically significant increase in creatinine, GFR has been observed after the first 48 weeks because it does not have staph. And it has been better not only for lipid friendly, but also even for the kidneys and as well as to the bones, which had been shown even in the previous study. And also they looked into the weight gain. It's very, very important, very interesting. What they found in that is greater weight change, which switched to doravirine/letrozole from baseline, especially patients who are on efavirenz or tenofovir. You see, it's been minimal weight change as compared to people who are without efavirenz and tenofovir. As many of you know that in the past, efavirenz causes weight loss. And tenofovir also causes, it does not increase the weight. Half increase the weight, and the bictegravir or dolutegravir increase the weight. So that's also been observed in this particular study. That's another reason that when we put patients on integrase inhibitor, they put on weight as compared to previous efavirenz, they were all been losing weight. That's been also been well demonstrated in this particular sub-study, in this particular trial. So investigator concluding stating that this can be a very safer combination of doravirine and letrozole and not depleting CD4. And today, as many of you know that we do have generic doravirine already been launched in our country last month by MCure, and hope the company will also bring out this letrozole, and they can put both as a single tablet, which can be a robust combination, especially for maintaining therapy and also for initiating treatment based on these studies. And similar like dolutegravir and 3DC, this can be another option even for resource-limited settings. So moving to these, the next two drug therapy is again a very interesting combination of oral letrozole. The earlier study which I talked about is everyday oral treatment. This is weekly tablet, which can be developed as a long-acting oral tablet, and along with lenacapavir, oral tablet as a long-acting every week, weekly once, patients can take it. So this particular trial was carried out on patients who have got suppressed viral load of TAF-FTC and bictegravir. They moved them to these weekly oral letrozole and lenacapavir. This is the design of the study of almost around 106 patients who had more than 350 CD4 undetectable viral load on TAF-FTC and bictegravir more than 6 months. They randomized one group to weekly tablet of lenacapavir and letrozole. Another group, here again, letrozole higher dose was used because it was a long-acting, and for a week, the everyday oral tablets was 0.25. And everyday oral therapy of TAF-FTC bictegravir was allowed to continue for up to week 48. Again, this group also been moved to weekly tablet, that's to a late switch, with the primary endpoint of viral load of more than 50 copies at week 24, and with several secondary endpoints. Again, in this found in that either it is early switch or late switch, they are able to maintain the viral suppression. And there are no failures been seen in putting on patients on this weekly tablet. And also when they looked into these adverse events of letrozole and lenacapavir, has been acceptable for various adverse event profiles. There is no serious adverse events. No one discontinued because of any adverse events, particularly with a combination of weekly letrozole and lenacapavir. And also they looked into very importantly into the lymphocytes and the CD4 cells. There is no significant changes. There are some changes in the CD4 count and lymphocyte and weight, but it was not been significant. No one discontinued because of this particular event of CD4 change or any weight changes or in BMI. So the investigator concluded stating that someone who's got a suppressed viral load with a TAF-FTC and bictegravir, they can be very safely to weekly oral tablet of letrozole and lenacapavir, which is again a very exciting combination. People don't need to take everyday oral tablet weekly once, especially on a Sunday they can take it, or on a Monday, whatever day they want on that. Again, this can be a future again, even from our generic market, once they all get this lenacapavir out, they'll be able to take this tablet, and this can be even combined together as a single tablet one day. So hopefully we'll have this particular exciting combination even for lower and middle income countries. Now I'm going to end my talk stating with some of those newer drugs in pipeline, but these are all in the very early phase. So this is a study called EMBRACE. I think to this group I have presented earlier, which is a broadly neutralizing antibody, which can be given called N6LS, along with recombinant human enzyme, where they'll have a vector dispersal when it's given as a subcutaneous, which was compared against, along with the long-acting cabotegravir against the everyday oral treatment. So what they did in this particular trial and presented here is on patients who have got suppressed viral load, they're randomized into 2:2:1 into either to the combination of this broadly neutralizing antibody. They're given a name to this called Lotivibart, along with every month of cabotegravir injections. And another arm received this Lotibart, which is a broadly neutralizing antibody with a human enzyme and with everyday injectable of cabotegravir, which was compared against everyday oral standard of care. And what they found in that particular trial is patients who received this intravenous Lotibart every 6 months and along with every month of injection have a higher virological suppression, but it's also been non-inferior as compared to everyday oral therapy. Again, it's another thing which is again a new data being presented. It can be another future treatment option. May not be for our lower and middle income country at this time, but it's been exciting because we need to have another partner drug for every 6 months, because currently cabotegravir is every 2 months. They're also developing every 4 months. If we develop every 6 months, or probably one day they can give this along with the lenacapavir when it's been available, can be future treatment options. Moving to the other long-acting newer drug, this is again a exciting molecule being developed by Gilead. It's under phase 1 development, which is a novel long-acting integrase, the 3rd generation integrase inhibitor, which will also have activity against the previous resistance to the currently available dolutegravir or bictegravir. And they also showed a PK data that it can be given up to 4 to 6 months dosing that can be long-acting, which can be paired very well with the lenacapavir, and have an excellent antiviral activity and also being potent against the current integrase resistance. So we need to wait for the phase 2 study, which is going to begin anytime soon. So currently, there is a proof of concept being presented where it can be a potent drug in future. Also, which is a GSK, also presented a long-acting integrase inhibitor, which is again a 3rd generation novel with a very good PK of every 6 months half-life, but can be given twice yearly and with good safety profile. And also, it can also be effective against the other resistant viruses to integrase inhibitors, and being given to bictegravir integrase and as well as dolutegravir resistant viruses. And now a trial called Innovate about to begin on a phase 2B further development of this. Wait for the results. These are some of the exciting molecules. Probably one day you'll use it in your clinics, pairing along with lenacapavir or other long-acting injectables. Also, there is a new long-acting capsid inhibitor being presented at this conference, which is a phase 1 study, again by the by GSK, which also can be developed every 6 months, twice yearly. And again, is a new compound, new class of drug. Phase 2 studies are about to be initiated soon, a study called Synergy, both as for subcutaneous as intramuscular, which is expected to begin. So these are some of those new combinations, probably will make it. They're gone beyond now into phase 2, along with the good potent drugs. Now, this all will make it to the future treatment guide. It might be in 2 to 3 years' time. It might be as part of our treatment practice. I like to conclude stating that with all this wonderful new molecule coming up, still HIV will persist. It is not a curable disease. So this is lifelong. Either you give everyday oral therapy or weekly oral tablets, or this long-acting every 2 months or long-acting every 6 months. It's going to be lifelong with the current science we have. Our job as a clinician is how we can prevent resistance. So here comes all these long-acting drugs, either as an oral long-acting or these long-acting injectable, which are all very high genetic barrier, can be a future option. Hence, understanding about these new molecules, knowing about them, and counseling the patients about this when now itself is preparing them so that when it's available, you can use it in your practice. I'd like to thank you again for the opportunity. Again, our future therapeutics, all towards will be long-acting, either oral or injectable. Thank you so much, and I'll stop here. I know the talk is quite long. Happy to take any questions.
Yeah, thank you very much, sir, for the very much enlightening, and you have given all the updates for ART which were presented during the Croi meeting. So you emphasize on the evolution study, the impact 2017 study in which adolescents were involved, lenacapavir case series, the artistry uh, clinical trials involving bictegravir and lenacapavir, also for doravirine islatravir, uh, and also oral islatravir and lenacapavir. And very heartening to say that there is also the development of third generation integrase strand inhibitors and new capsid inhibitors. So the research for HIV treatment is now in a very exciting phase. So with this, sir, can I take a few questions?
Sure.
Okay. So first of all, I'd like to inform you that Dr. K. Satish from Bangalore has given given that there is an excellent talk on update on HIV treatment, and is thanking you for it. So we'll take now a few questions. So
Thank
one
you,
of the
Dr.
questions.
Satish. Yeah. Yeah, go ahead.
So one of the questions is from Dr. Swami that can we switch patients on long-acting drugs to two-drug regimen if the patient is not willing to go for injectables, orally suppressed patients? So based on your
Sure,
experience,
definitely. I think the clinical trial data also showed, people who are on long-acting injectable, even who had a failure also, when they moved them to everyday oral therapy, everybody got suppressed. So that means the answer is well, yes. You put them on oral therapy, move them to long-acting, they don't like it or they don't want it, can you definitely move them to everyday oral tablet.
Yes, sir. So now this is one big question. This is from Dr. Praveen Kumar from Manipal. So he is asking one or two questions. First is dual therapy trials, that is Gemini Tango, Darling and Volvo with dolutegravir lamivudine are predominantly from Western, Latin American, and some Asian countries.
So
Seemed
I
to
think
be
I can answer this question. A lot of people have asked. Since I'm also part of the WHO guidelines committee, I was been involved also in recommending this two-drug therapy. So I think this question from Dr. Praveen, we have a lot of NNRTA resistance failures and previous resistance. How we are going to use rilpivirine? So I think in my presentation I said when LATE-2, Atlas, FLIRE, these trials were done. US DHS's guideline they recommended in March 2024 on this two-drug long-acting injectable of rilpivirine and cabotegravir. But in WHO guidelines, didn't recommend that, because not because of any science, because we waited because that was done in a population where they did not have much NNRTA resistance. So we waited for developing country trial. So that's a study, CARE study, very nicely done study in sub-Saharan Africa, where a lot of NNRTA, where the baseline resistance is anything from 12% to 30%, where patients even who had the previous NNRTA documented failures. So all those, when they use this, where they use is cabotegravir and rilpivirine, they are able to have comparable virological suppression as compared to the standard of care. So I think following that study, so the guidelines panel voted very highly to recommend this. Hence, this WHO guideline. Hence, it is not a premature thing. It's based on science, where it worked very well. Thanks.
Yes, sir. I think some questions, sir, will take up like, for example, in your talk, you have mentioned different clinical trials were there. So one of the question was that instead of bictegravir, can we replace with dolutegravir in the combination of DTG and lenacapavir?
Of course, definitely. Now, currently, the one study which I presented is all done by Gilead, who are the innovator of lenacapavir and bictegravir. So they don't have dolutegravir, and so that's what they've been did with that. So as you all know, that bictegravir and dolutegravir is interchangeable. So I think a company like MCure, where you have a dolutegravir, the day when you develop your lenacapavir, you can put this all together. It's definitely possible.
Yes, sir. Yes, sir. Thanks, sir. And sir, in this CROI conference, or based on your exquisite knowledge on HIV. Are there some maturation inhibitors or attachment inhibitors in development? Some
So
science on that?
yeah, there are several, there are, of course, I didn't do a lot of presentation because we don't have a time on that. There are several presentations on the preclinical studies, especially on maturation inhibitors and as well as attachment inhibitors, and as well as on CD4 depletion receptor at that level. And also there are some of those on the which works at the at the molecular level of translation transcription. So these are too early. They're not gone into the step. The one I presented 4 early phase studies. These are all in the phase 1, going into phase 2. They already have moved into the phase 2. They are about to enroll patients. So I think the other molecules are still in the very early on that.
All right, so finally, so was there any data on first-time survey? Is one of the
Yeah, of
new
course. There
drugs
is not.
coming drugs.
Yeah, that's not a new drug anymore. It's been presented in many, many meetings, and they had some adverse events. Now, some modification has been done. So the company is moving forward in a very different way. By the time there are a lot of interest, they have now a lot of other new molecules coming up. So the interest on first user has been, going down. Now a lot of the interest is on long-acting drug. So if something you can't do a long-acting, nobody's interested anymore in the new molecule. So all the new molecules now getting developed all have some activity on the long-acting. Otherwise, the companies are not moving forward.
Yes, sir. Yes, sir. So, Dr. Swami has mentioned that he's thanking you very much for your talk, wonderful talk. And sir, he's saying that you're the only person who keeps on updating us on the newer drugs which are in the pipeline. So he's
Thank you.
complimenting that. Thank you, sir. Thank you.
Thank you.
Thank you. And again, this is a very awesome presentation, sir. So actually, there are some basically these are the updates, and he wants to know any advancing attempting to cure HIV or any vaccines which are in development, and your views on HIV vaccines actually.
Yeah. So there are several vaccines in pipeline. Many of them are killed, did not have efficacy or for various reasons. So right now, vaccines are under development, but nothing to say that it has been effective. The only vaccine we have now is called lenacapavir as a PrEP, so which has been very effective. Even I didn't talk anything about prevention in this meeting, where again new data presented on the follow-up of this earlier PROMISE study, where they found again continued prevention of every 6 months of lenacapavir. I think I will call currently that as a vaccine for HIV in the absence of any other thing, but that has to be given again, every 6 months. So coming to this other on cure, of course, there are several studies ongoing. They are promising, especially combination of antiretroviral treatment and a broadly neutralizing antibody or one of those monoclonal antibody, trying to get the virus, purge the virus from the reservoirs out and get it out. Now, these are all very promising, but right now we don't have a cure yet. But it is in the reach, but we do not know when is that reach. So it's quite possible.
Right, so well, sir. Like for example, we'll take one more question and then we can close. So any data, sir, on any long-acting TLD injections?
I know this question will come. So I think it is under development. So as you know that our group has been involved in this developing. It's too early to say that. So it is the pipeline. So it is, I think, going to be needed of the hour for resource limited setting, particularly in the context of tuberculosis, pregnancy, and as well as in hepatitis B. And there are other groups also been developing on this. So I think we need to wait. So probably the next Croi or so, we may have some data on this long-acting TLD. Either it is every month injections or every 2 months or every 6 months is something work in progress.
Yes. Thank you, sir. Thank you, sir. So thank you, sir, for today's Croi's updates. And as usual, sir, you are presented the ART updates which are there, and I'm sure the doctors who have benefited from all these updates. So now I will again hand over back to Balaji, sir, for proposing the vote of thanks. Thank you, sir. Thank you so much.
Thank you.
Thank you, Doctor. It was very interesting to listen to you. It's not an easy task to compress the discussions of a 4-day conference into a 45-minute presentation, and you did very well. We certainly look upon you, and it is especially for people in resource-limited settings. These are very good insights into what could be the future of in HIV treatment and prevention. So please do continue your good work, and we thank you very much for consenting to be with us for this webinar. Have a
Thank
good
you.
day.
Thank you. Thank you so much for inviting, and thanks everyone for your patient hearing. Have a good Saturday evening. And if you are in India, enjoy cricket. I'm sure Chennai Super Kings team would have started. We are doing badly, but hope to win today. Enjoy.
Thank you.
Yes,
Thank
sir.
you.
Thanks. Same to you, sir. Thank you so
Thank you.
much. Thank you.